Tacrolimus. Tacrolimus, it's also named as FK506 and it is obtained from a bacterium Streptomyces succubensis. So it is the first US FDA approved was in 1994 and it is a calcineurin inhibitor. And the character of the drug is it is insoluble in water and almost soluble in alcohol. So it is soluble in ethanol and methanol and chloroform. And the pediatric heart transplant recommended dose of 0.3 milligram per kg per day in two divided doses. And the recommended TAC level in blood during the first 1 year of transplant is 5 to 20 nanogram per ml, between 5 to 20 nanogram per ml. So the drug is available as capsule, injection and oral suspension. Capsules 0.5, 1 milligram and 5 milligram, injection 5 milligram per ml and oral suspension of 0.2 milligram and 1 milligram unit dose packets containing granules. So what is the mechanism of action? It's basically binds to a protein, intracellular protein, that is FKBP12. And along with FKBP12 tacrolimus complex, calcium, calmodulin and calcineurin bind, and this complex will inhibit the phosphatase activity of calcineurin. So when that is inhibited, so there are activation factors of B cells and T cells. That is nuclear factor activated T cells and nuclear factor kappa light chain enhancer of activated B cells. So when these get dephosphorylated only, they become active. So the dephosphorylation is inhibited because of the binding of calcineurin with the tacrolimus complex. So it tacrolimus prevents the dephosphorylation and translocation of these factors which activate the T cells and the B cells. So in turn, because of this is not happening, it will further inhibit the production or and expression of several cytokines like interleukin 1, 2, 3, 4, 5, 6, 8, 10, gamma interferon, tumor necrosis factor alpha, and granulocyte macrophage colony stimulating factor. It also inhibits the expression of the interleukin 2, nitric oxide release. It induces apoptosis and production of transforming growth factor beta, which all leads to the immunosuppressive activity. So basically, net result is T cell activation and proliferation is inhibited, as well as T helper cell dependent B cell response is also inhibited, which results in immunosuppression. So this is 99% plasma protein bound and over a concentration of 5 to 20, 15 nanogram per ml, this is 99% plasma protein bound only. And it mainly binds to albumin and alpha 1 glycoprotein and is highly associated with the erythrocytes in the blood. So it was found in a trial that it is 35% times more concentrated in whole blood compared to plasma. And the distribution between the whole blood and plasma depends on the hematocrit, temperature at the time of plasma separation, drug concentration and the plasma protein concentration. So it basically after oral inhibition, oral uptake, it goes biotransformation is basically demethylation and hydroxylation occurs. So contraindications for use of tacrolimus include hypersensitivity to tacrolimus and also intravenous preparation, particularly allergic to HCO60, which is a polyoxyl 60 hydrogenated castor oil. So these are the contraindications because IV preparation has that. So what are the warnings and precautions? That is, there is a difference between the pharmacodynamics of immediate release as well as the extended release preparation. So we should be careful what type of preparation is we are using. It is always the immediate release which we are talking here, and whenever the patient is shifting to an extended release preparation, it should be under the supervision of physician only. So tacrolimus is known to cause new onset diabetes after transplant. So monitoring your blood glucose is important. It causes nephrotoxicity. So with other nephrotoxic drugs, dose reduction is important. It is known to cause posterior reversible encephalopathy syndrome. So dose reduction and discontinuation is required. It is known to cause hyperkalemia. So careful with other hyperkalemic drugs. It can cause hypertension, anaphylaxis because of the presence of HCO60, polyenol castor oil, and it is not recommended for use with the sirolimus, particularly liver transplant, because it is known to cause hepatic artery thrombosis. It is known to cause myocardial hypertrophy, increase the interventricular and the posterior wall thickness. In that case, you have to discontinue or reduce the dose. And live vaccine should not be administered when the patient is on tacrolimus, because it is an immunosuppressant, so it will cause the disease, particularly intranasal influenza, measles, mumps, rubella, oral polio, BCG, yellow fever, varicella, and TY21A typhoid vaccine. And it is known to cause pure red cell aplasia. In that case, we have to discontinue tacrolimus because it is more concentrated in the RBCs and it can affect the RBC synthesis. Other common adverse effects is abnormal renal function, hypertension, diabetes, fever, cytomegalovirus infection, tremor, hyperglycemia, leukopenia, infection, anemia, bronchitis, pericardial effusion, urinary tract infections, constipation, diarrhea, headache, abdominal pain, insomnia, paresthesia, peripheral edema, nausea, hyperkalemia, hypomagnesemia, and hyperlipidemia. So, SAB patient can come with nausea, peripheral edema, tremor are the common presentation we see. It can cause bronchitis also, and also pericardial effusion, UTI, bowel symptom, constipation, diarrhea, etc. So it is basically metabolized by the CYP3A. So when there is a CYP3A inhibitor, it will increase the level of tacrolimus. So we should be careful and regulate the dose. Like particularly the CYP3A inhibitors include teliprevir, boceprevir, ritonavir. Also this that common voriconazole, posaconazole which we use in the ICU, itraconazole and clarithromycin. And when there is a CYP3A inducer, it will reduces the level, so we should be careful. We should increase the dose. So I say rifabutin and rifampin. And so posaconazole and voriconazole increases TAC levels, while caspofungin reduces the TAC levels. Underexposure or overexposure to tacrolimus may result in graft rejection or serious adverse effects. So immediate release and extended release physician supervision is required. We should not simultaneously give cyclosporin and tacrolimus. So when you are changing from cyclosporin to tacrolimus, an interval of at least 24 hours should be there. And in patients who are post liver or heart transplant, it should be administered after 6 hours of transplant. And if there is an already deranged liver function, it can be further delayed. And in a post kidney transplant, it is usually administered within 24 hours. It is not like after 6 hours you have to administer it, within 24 hours and or further later if the patients till the renal function improves. So in adult patients, so pediatric we have discussed the doses 0.3 milligram per kg, divided doses 12 hourly with a monitoring of 5 to 20 nanogram per ml in the first 12 months. So in adults, the dose is 0.075 mg per kg divided in 2 doses given 12 hours apart, usually along with azathioprine or methyl MMF. And in the first 3 months, we aim for 15 to 20 nanogram per ml, 10 to 20 nanogram per ml, and in the more than 4 months, we aim at 5 to 15 nanogram per ml of a tacrolimus level. So it is administered along with azathioprine or mycophenolate mofetil. So usually for maintenance therapy, that is the initial dose. Okay, but after that maintenance therapy, we give for go for a lower dosages. And if you are giving IV infusion, should be given only as continuous infusion, and it should be stopped as soon as the patient start tolerating oral. And if it is we are giving intravenous infusion, the dose is 0.01 mg per kg divided per day as continuous infusion. And if you are converting from infusion to an oral dose, at least 8 to 12 hour gap should be present between the IV infusion and the oral dosing. So if the patient has a already renal dysfunction is there in a liver and heart transplant, we aim for a lower level of tacrolimus level at lower doses administered. And if there is severe hepatic impairment, that is child score is more than 10, also require lower dose of tacrolimus. So to maintain the normal between the level, like in adult we want between 10 to 20 in the first 3 months and 5 to 15 in the more than 4 months. So drug monitoring, therapeutic drug monitoring is very important. Not only for other than hepatic and renal dysfunction, because along with this we will be giving other drugs which will be which can increase or decrease the tacrolimus level, and also depend on the post transplant time, also the level required will be different. So it is important for therapeutic drug monitoring. And this drug dosages will change initially maximum in the first week after transplant. So monitoring your whole blood trough concentration is recommended to assist in the clinical evaluation of toxicity and efficacy failure. And methods are by high performance lipid chromatography, tandem mass spectroscopic method, as well as immunoassays are there. Immunoassays are not preferred because the metabolites can, as well as the parent compound may react and may or change the levels. So whole blood EDTA sample is taken, and anticoagulant is EDTA, and it can be stored in room air up to in refrigerator up to 7 days. So we have capsules of 0.5 milligram, 1 milligram and 5 milligram, and there are different color codes, that is light yellow color for 0.5, white color for 1 milligram, which is imprinted in red. So 0.5 and 1 milligram tablets are imprinted in red, while red color is because higher dose, no? So it is red color 5 milligram, imprinted it with white, and they are written F607, 617 and 657 respectively. So what are the possible malignancies which can occur is lymphomas and skin cancer. So proper exposure from ultraviolet rays and a frequent skin examination is very important on those patients taking tacrolimus. Also post-transplant lymphoproliferative disease, particularly with Epstein-Barr virus, more common in young children, is a non-complication of tacrolimus. And this is a risk is highest on those recipients who were EBV seronegative. So we should be very frequently monitoring the EBV serology also of those patients receiving tacrolimus. And other complications include polyoma-associated nephropathy, mostly due to BK virus infection, then JC virus-associated progressive multifocal leukoencephalopathy, and cytomegalovirus infections. Who receive this is more in CMV negative, seronegative patient who receive a transplant from a CMV seropositive donor, a telephone CMV viremia disease. And risk of a nephrotoxicity, it will increase when you are giving along with a CYP3A inhibitor, because it will increase the tacrolimus and further cause nephrotoxicities like or other antibiotics nephrotoxic like tacrolimus, amphotericin B, and nucleotide reverse transcriptase inhibitors, ganciclovir, cisplatin, and protease inhibitors. And calcineurin in calcium channel blockers increase tacrolimus blood concentration, so dose reduction is required if you are giving concomitant. So sirolimus, there was increased risk of a renal function impairment in heart transplantation. In kidney transplant, in liver transplant, this increases the chance of hepatic artery thrombosis. So wound healing can be complicated if you are using sirolimus. And insulin dependent post transplant, also diabetes also develop in those receiving sirolimus along with the tacrolimus in post heart transplant. So it prolongs the QT prolongation. So those having congenital QT prolongation and those drugs which prolong QT, we should be careful in giving tacrolimus with tosadis pointers can be precipitated. And it is found that amiodarone increases. So amiodarone, voriconazole, voriconazole, posaconazole all will increase the level of tacrolimus along with or without QT prolongation. And myocardial hypertrophy, if it happens, we have to reduce or discontinue the drug, usually echocardiographically assisted, using increase in the left ventricular posterior wall and interventricular septal thickness. So if an overdosage happens, it concentrates more on RBC, so it is almost like distributed inside the tissue, so it is non-dialysable. And there is no experience with charcoal hemoperfusion also. So where there are reports of oral use of activated charcoal has been reported in treating acute overdoses, and but experience has not been sufficient to warrant recommending its use. So this is in short about tacrolimus. Thank you.